Hello my friends, Dr. Said Kazmi here once again. Welcome to my YouTube channel. Today we will be talking about tachyarrhythmias, and especially in tachyarrhythmias the focus of this talk would be on supraventricular tachycardias, or SVTs as we call them. So let me start with the definition. SVTs as a part of tachyarrhythmias are not that much common in pediatric practice, but once in a while you do come across these children who would be suffering from this condition. And the issue is that it's very important to recognize this well in time, because if you miss and this SVT as a part of the problem, if it continues in that episode, that can have dire consequences for that particular child. So the definition is that, like in very simple words, this is an abnormally fast heart rhythm. Abnormally fast heart rhythm. So heart rates have got a range, and this range actually varies according to the age of the child. Like for example, a heart rate range, a normal range, which let's say is 120 to 160 for a newborn or an infant, might be considered abnormal for an older child. So the heart rate range actually varies with the age. So for that age group, if the heart rate is way above the upper range of the normal, we call it as tachyarrhythmias. Arrhythmia means, because that's not the normal rhythm. Tachy means fast. So it's not on the slow side, it's on the faster side, it's on the higher side. So fast heart rate. Now again, as I told you, that you have to consider the age group of that particular child where you are considering this thing, and it would vary. But as a general rule, heart rate which is above 250 beats per minute, irrespective of the age of the child, is considered as tachyarrhythmia. So you have to, first of all, you have to look at the age group of the child. But if not, and at the top of the head you don't remember it, any rhythm with a 250 heartbeat and above would be classified as tachyarrhythmias. Now the focus would be on SVT as part of the tachyarrhythmias, because these tachyarrhythmias could be either SVTs or it could be ventricular rhythms as well, like ventricular fibrillation and ventricular tachycardia, which are much more serious conditions. I have reserved those topics for another lecture somewhere in the future. Now, important thing is to recognize this rhythm well in time. You need an ECG for that purpose, because the only way to know if it is SVT or VT is through an ECG. Or even if the ECG is not there, you need a cardiac monitor to at least look at the rhythm. Now, normally SVTs as part of tachyarrhythmias are usually well tolerated in children. So if it goes off for, like, let's say a couple of minutes, the child is still fine. They would be having some symptoms, but there is no immediate threat to the life of the child. But if the thing goes on, for hours, if it persists beyond 6 hours, then there are more chances of that child developing congestive heart failure. So that child would be developing heart failure, or would develop poor left ventricular functions, which you don't want any child to end up. You don't want any child with these rhythm problems to end up in congestive failure or in poor left ventricular function, because these can be a serious threat to the life of the child. Now, let's start with the etiology. What causes this abnormal fast rhythms? So broadly, we classify them into two groups. One are the structural heart problems. So at the base of these issues is a structural heart problem. So structural means like there is something wrong with the structure, with the anatomy of the heart. And again, that could be congenital, where the child has been born with this condition. Like for example, a child born with an abnormal heart, like in Epstein anomaly, or tricuspid atresia, or single ventricle, or tetralogy of Fallot. So all of these structural heart problems which are present at the time of birth, and somehow they can give rise to supraventricular tachycardias. I mean, it doesn't mean that each of these cases would be, or all of these cases would be having SVTs, but it can produce SVT. So congenital structural heart, or it could be acquired. So for example, a child undergoes cardiac surgery for one reason or the other. So when he's undergoing cardiac surgery, obviously the myocardium is cut, and somehow if the incision is running through the, let's say, through the conduction bundles of the heart, then it might lead to problems later in the life in the form of SVT. So structural heart problems are either congenital or either acquired. And then if they don't have structural heart problems, they might be having physiological problems. That means there is some problem with the conduction pathways. So the electrical impulses are generated in the right atrium at the SA node, and then they travel down to the ventricles from the normal AV bundle, which is known as the bundle of His. Now this is the normal bundle. Now sometimes some kids can have an accessory, a separate bundle, conduction bundle. It's like extra pair of wires running from the atria to the ventricles, which is known as the bundle of Kent. So bundle of Kent is basically an accessory bundle. Now because it's an accessory bundle, the thing is that what you call a wave can go through the bundle of His and come back through the bundle of Kent, or it can go through the bundle of Kent and come back from the bundle of His. So so what would happen? Let's say if one electrical impulse goes quickly through one of these bundles, it's going to come back. It doesn't mean that in all cases it will come back, but in some cases it's going to come back and then re-excite the atria and then go through the same thing. So it would lead to a vicious cycle of excitation and contraction and excitation and contraction, and that would lead to abnormally fast rhythm. Or they can have what we call as a functionally separate bundle. So there is a single bundle of His. I mean, anatomically you can't recognize that there is a separate conduction bundle, but within the same bundle, functionally there are two pathways. So one is a normal pathway and one is the accessory pathway. So things can go either antidromic or orthodromic, and forth and back between atria and ventricle, and that would lead to a vicious cycle of excitation and contraction, and that would lead to a very fast heart rate, which we call as an SVT. So this is the etiology. So it could be a structural heart problem, or it could be a physiological problem. Again, it depends. So once you have dealt with the initial rhythm abnormality, let's say you have addressed that issue in the ED, then the next step, if it has not been worked up, you need to work up to see what's the underlying cause. So you have to find if there is any structural heart problems. You might have to do echocardiogram or like some other investigations, or you might have to do electrophysiological studies to see if there are underlying like physiological conduction problems. Okay, so this was etiology. Now let's talk about the clinical presentation. Now, clinical presentation in older children, those who can talk, who can express their symptoms, by and large, palpitations, thumping sensation in the chest, they say like something is thumping in the chest, or sometimes they can visibly see beats their chest. So palpitations are the most common symptom in older children. The symptoms in infants are quite subtle. Infants, they can't express what's wrong with them. So SVTs in children can present with subtle symptoms. These babies would be very fussy, they are irritable, they might have poor color, so they might be having pallor, and they might be having cold extremities or mottling of the skin. They might be crying excessively, or sometimes they can frankly present as a cardiovascular collapse, like all of a sudden absolutely fine baby, and within minutes or hours just collapses and is brought as a priority call. So in infants, the symptomatology could be quite subtle, and obviously when you are doing the triage, you're taking the vitals, then you'll pick up an abnormally fast heart rate, usually more than 250 beats per minute. So in younger children, infants, mostly subtle symptomatology. In older children, it's mostly palpitations or thumping sensation in the chest. It might also be accompanied by some other symptomatology, like with the palpitations, they might be complaining of chest pain or tightness in the chest. They might complain of generalized weakness and dizziness. They might complain of nausea. They might complain of a generalized numbness in the body. So most of these kids, when they are being triaged for one reason or the other, they would be picked up at a triage, because heart rate is part of this vital signs which is done at a triage. So they might be picked up at triage, and the nurse tells you to come on quickly, see this child who's got a very fast heart rate, and then you do the ECG, and then you may be able to pick up the rhythm problem. So this is how these cases of tachyarrhythmias of SVT, they present to you. Now coming down to the management. The management, we divide them into two parts. One is the initial management, and the other is the proper management. I apologize, I think if you can hear a sound of barking in the background, it's my neighbor's dog who is barking. But anyhow, please bear with me, I can't do anything about that. So coming back to the topic, management is divided in two parts. The initial management, which means the emergency treatment of these rhythm problems. That means converting these rhythms back to normal rhythm. So fast heart rate has to be brought down to the normal heart rate. And the second one is okay. Now talking about the management is divided in two parts. So one is the initial management and the other one is the specific management. So the initial management means like once you know that the heart rate is very fast, you immediately need to shift that child to the resuscitation trolley. You need to attach the monitors. You need to start them on high flow oxygen, so at least 15 liters per minute of oxygen through a non-rebreathable mask. Because obviously these conditions might be associated with poor cardiac output and that would lead to oxygenation problems. So attach the monitors, start them on high flow oxygen, access IV lines because the medications would have to be given intravenously, so you need to secure IV lines. So at least one IV line. If you can even secure two IV lines, but at least one you have to secure. And you have to put them on cardiovascular monitoring. And the very important thing is you need to get a 12 or a 15 lead ECG because you need to identify the rhythm. The further management, whether you have to treat it with adenosine or any other thing, it depends on whether the rhythm shows you an SVT or any other abnormal problem. That would only be done by ECG. So as you have attached the monitor, also take a 12 or a 15 lead ECG and see if the child is hemodynamically stable or unstable, because again that would change the management. The child is hemodynamically unstable, then you have to cardiovert that rhythm abnormality. If the child is stable, then you have to go down the what we call as chemical cardioversion by giving them adenosine or some other medications if needed. Now normally we try, first of all we start with vagal maneuvers. So vagal maneuvers again depends on the age of the child. For older children, we can ask them either to blow in a tube, or let's say try to blow up a balloon, or do forced Valsalva maneuvers like squatting, closing their glottis, trying to push air against a closed glottis, or you can also do a maneuver in which the head is tilted down and the body is pushed up, like the legs are like sort of raised up to increase the vagal pressure, and that can sometimes terminate the SVT. So you can start with vagal maneuvers. For younger children, the one thing that is recommended for infants is like ice in a bag or maybe in a glove, and then you attach it to the face for 10 seconds and you can repeat it a couple of times and see if that helps in breaking down the rhythm. So these are vagal maneuvers. Again, depending on the age of the child, you start with vagal maneuvers to see if that works or not. So if it works, your rhythm is broken down, well and good. If not, then you have to move on to the next step, and that is we call specific management. So again, as I told you, specific management depends whether the child is unstable hemodynamically or whether he's stable. Now here, for sake of your interest, I would like to quote three things. Number one, I would like to quote the treatment from the APLS or Paul's algorithms, number one. Number two, I would like to state the treatment which is recommended in one of the finest textbooks of pediatric cardiology, which is known as the Parkes Pediatric Cardiology for Practitioners, and the references would be from the 2021 edition of the Parkes Practice of Pediatric Cardiology. And number three, I would like to give you some references from the Fleischer and Ludwig textbook of Pediatric Emergency Medicine, which is another like Bible of Pediatric Emergency Medicine. So again, so you can have like sort of an this view of the treatment of this condition from all the three standard texts. So let's start first thing from what the APLS or Paul's they say. So Paul's, again, it divides the specific management according if the child is unstable or stable. So let's say if the child is unstable, let's say the child is in shock or unconscious or hemodynamically unstable, Paul's or APLS algorithms, they talk about cardioversion. So you have to do electric cardioversion. So the Paul's algorithm, they say like you have to start with 1 joule per kg and you have to cardioverse. So this is synchronized cardioversion, 1 joule per kg. So you have to give this electrocardioversion. If it doesn't work, then you can move from increase the dose to 2 joules per kg. And if it still doesn't break down the abnormal rhythm, then you can go to a maximum of 4 joules per kg. Most of the times 2 joules per kg usually breaks the rhythm. So you have to do electrical cardioversion, synchronized cardioversion, 1 joule, then 2 joules, then if it doesn't work, 4 joules per kg body weight. So that should work. If it still doesn't work after the maximum dose, then you have to move towards the chemical cardioversion, where you have to give some chemical medication, usually amiodarone. If the child is stable, then the APLS or pulse rhythm, they talk about adenosine. So adenosine is a short-acting medication that blocks the conduction at the AV node. It's a very ultra short-acting medication, just like the half-life is a few seconds. So it has to be given IV and has to be given very fast. So it has to be given an IV push, and then you have to flush it so that like it just goes directly into your central circulation. And it says that it's recommended for all regular narrow rhythm SVTs. So the dose that is recommended by the APLS or pulse algorithm is 100 microgram per kg. So you have to start with a low dose, that is 100 microgram per kg. Again, you can go to up a maximum of 6 in the, if the child it's a bit heavy. So that should terminate. If not, you can repeat the dose, this time with an increased dose. That would be 200 micrograms per kg body weight. And if it still doesn't work, then you can go to a maximum of 300 microgram per kg body weight. So you start with 100, doesn't work, you move up to 200, still doesn't work, you move up to 300 microgram per kg. The upper limits are 6 and 6 milligrams for the first 2 doses and 12 milligram for the third dose. You cannot go beyond that. Like if the child is very heavy, because you will have to stop at 6 or 12 milligram respectively. This adenosine is therapeutic as well as diagnostic. Therapeutic because in most of the cases on the first or the second or the third dose, the abnormal rhythm would be broken down and would be converted back to the normal rhythm. Sometimes it might break the rhythm and then it may recur, but what you would see that time during which the rhythm comes back to the normal, it might unmask an underlying problem which you did not see in the very first abnormal ECGs. Like for example, if there is an underlying atrial flutter, like flutter waves or atrial fibrillation, obviously because the rhythm is so fast you can't see it on the initial ECG, but when it converts back to the normal, the slow rhythm, you might see the flutter or the fibrillation waves before it goes back into abnormal rhythm, because the medication was ultra short acting, it's been metabolized, the child goes back into the abnormal rhythm. So that's why it is therapeutic as well as diagnostic. For all irregular means like the rhythm is, it's obviously it's a SVT like a narrow complex, but if it is irregular, then they say you should not be giving adenosine because there might be a possibility of underlying atrial fibrillation or Parkinson-White syndrome, and in that case if you give them adenosine, it might throw the child into a frank ventricular fibrillation. In that particular case, you should be considering beta blockers like IV propranolol. So this is what the APLS or pulse, APLS is, we call it APLS or e-pulse in UK. In America they call it the pulse. So this is what that recommends for the treatment of SVT tachyarrhythmias in children. Now let me give you the reference from the Parkes Pediatric Cardiology 2021 edition. So here, if you see, the doses are a bit different. So Parkes Pediatric Cardiology recommends lower dosing. So it says that adenosine should be started from 50 microgram per kg. So instead of 100 in APLS, this recommends 50, and you should be increasing it in increments of 50. So if you give 50 microgram per kg, then the next dose should be 100, then 150. So there's no limit. Like in APLS, it says like first 100, second 200, third 300. So only 3 set of doses can be given. Here you can increase in from 50 to a maximum of probably 5. You can go to a maximum of 250 microgram per kg, in sort of an incremental increase till the rhythm is converted back to normal. So this is what the Parkes Pediatric Cardiology recommend. Similarly, for those who cannot be those who are unstable or those who cannot be converted by chemical methods, they recommend electric cardioversion, but here the dose is 0.5 joules per kg and in step of maximum of 2 joules per kg. So instead of APLS of 1, 2 and 4, this one recommends starts from 0.5 joules per kg and goes to a maximum of 2 joules per kg. And here, instead, in like sort of an irregular rhythms, then it recommends propranolol instead of adenosine, because as I told you that there's a possibility of Wolff-Parkinson-White syndrome with an underlying atrial fibrillation, which might give you an irregular narrow complex tachycardia, and if you give adenosine, that can actually convert it into full-blown ventricular fibrillation. That's why they actually recommends IV propranolol, or if IV propranolol is not available, esmolol, or in certain cases digoxin as well. And it also recommends, if everything else fails, transesophageal pacing, in those children who have been digitalized, so that can also be used. So this is what the Park's Pediatric Cardiology recommends for the treatment of SVTs in children. Now, coming to the third reference, and that is the Fleischer and Ludwig textbook of pediatric emergency medicine, the 2021 edition. It says that if you give adenosine, it can result in one of the three outcomes. So if you give adenosine, it can do three things. Number one, it may have no effect. Number one, it doesn't work at all. You give the first dose, it doesn't work. Number two, it works. It just like converts the rhythm back to the normal. Or number three, it works temporarily. It like works for a few seconds where it breaks the rhythm to the normal and then the rhythm comes back. So three possibilities. It works, it doesn't work, and it works for some time before going back to the same SVT. So they say if it does not work, then you have to give a second dose. And again, it depends, you are following APLS or you're following Park's Pediatric Cardiology, you just increase the dose till you can break the cycle, or you reach the maximum dosage. So once it is broken down, obviously problem solved. Number two, it works for the very first time. That's fine. If it works, you just attach the child to the monitors and you take another ECG. This is very, very important, that once the rhythm is back to the normal, you take an ECG, you look for any underlying problems, you put the child on continuous like cardiovascular monitoring, and you admit them, because it might come back, or you have to see what if a child has an underlying problem, then what were the predisposing factors that threw the child into an SVT. So have to have some further workup as well. So if it terminates the rhythm, as I said, like you have to admit, put the child on cardiovascular monitoring. What if it works for some time? Now that sometime is very important, because in that sometime you need to get the ECG or find the underlying abnormality before the abnormality comes back, like the SVT comes back. So let's say if there was an underlying atrial flutter or underlying atrial fibrillation, then you have to treat it accordingly. So in that particular case, they say that you might have to consider other medications. For example, you can consider IV procainamide, you can consider IV esmolol, or you can consider IV amiodarone. They say channel calcium blockers should not be used in patients less than 2 years of age, or in combination with beta blockers, or those who have got poor ventricular function. So if the left ventricular function is compromised, the child is less than 2 years of age, or already you've used beta blocker, don't use calcium channel blockers, because that can kind of worsen the condition. And it says cardiology consultation is advised. If adenosine fails to convert tachycardia at all, electrical cardioversion is indicated. So it says if you can't do it by chemical methods, then you have to use the electrical methods. You have to do a synchronized electric cardioversion. So this is what the Fleischer and Ludwig textbook of pediatric emergency medicine recommends about treatment of supraventricular tachycardias. So to summarize it, from management point of view, it's very important that once you get the ECG rhythm and you've got a narrow complex tachycardia, see if the rhythm is regular, because you need to have a regular rhythm if you want to give adenosine. If you see that narrow complex is irregular, then hold on to adenosine, rather use other medications like procainamide, or normally we recommend IV propranolol. It's a safe medication, okay, and especially if the child is known to have Wolff-Parkinson-White syndrome, or even if you don't know that there's underlying Wolff-Parkinson-White syndrome, but the SVT or the narrow complex tachycardia is irregular, then in that case it's better to use IV beta blockers rather than adenosine. So adenosine has got a short half-life. It's quickly metabolized, so it has to be given very quickly. It can be given incremental dosage. You have to increase. Remember, it has got some side effects. It can cause a sense of impending doom. It causes bronchospasm, and it can cause sometimes apneic spell as well, especially in very young children. So this was all about the management of tachyarrhythmias with focus on SVTs and their management as recommended by standard textbooks of pediatrics. I hope you have liked this video and learned something, and if you have liked this video, smash that like button, share it with your friends so they can also learn something. And if you haven't subscribed to my channel, please do subscribe and press that bell notification icon so whenever I upload a new video, you're always on board with me. So have a very good day and take care, and bye bye.